Okay, hello everybody. Welcome back. This is going to be your lecture for chapter 24, abdominal pain and gastrointestinal disorders. I will go ahead and warn you right now, this is definitely not the most exciting chapter that we go over. And a lot of this you've had already in your EMT training, but let's dive into it and get you a cup of coffee, get you something to kind of help you get through it, because you're probably going to need it. That's for sure. All right, so let me introduce the chapter. Gastrointestinal disorders, they often present with abdominal pain. Not all abdominal pain, though, is caused by gastrointestinal disorders, because they can reflect problems with the renal or urinary tract problems. Could be a vascular disorder, could be a GYN disorder, a pneumonia or myocardial infarction. Sometimes, especially guys and females, a lot of times myocardial infarction, they'll complain of an abdominal pain, and obviously as well as GI disorders. Let's do an AEMT review of the abdominal area. It's divided into 4 quadrants by 2 imaginary lines that intersect at the belly button. You have abdominal organs are, some of those organs are hollow, some of those are solid, some of those are peritoneal, and then retroperitoneal. All right, so let's just kind of go through this. Here we have the pancreas. This is the duodenum, the mesentery. Here is the large intestine, the rectum. Here's your stomach. And you can kind of look at this, the uterus and a female's urinary bladder. Here's the divisions of the 4 abdominal quadrants. Again, you need to know what organs lie in what. You need to understand that the majority of the liver we have in the right upper quadrant here, but it also extends to the left upper quadrant. And we have the lower quadrants as well. So one of the largest blood vessels that we have to be concerned with is the abdominal aorta, right? With the vena cava, the renal arteries and veins, and the hepatic portal. Talking about the liver there. The gastrointestinal system really it starts as a long tube as the esophagus and moves down all the way to the anus. So we have a lot going on there. As you can tell, here's the whole GI system. It starts up here in the oral pharynx. Why? Because of the digestive juices that mix with this, saliva helps to start breaking down food and processing it, coming down the esophagus, and you know the track. So when we talk about the stomach and intestines, the stomach content is known as chyme. It enters the small intestine right there, and that's at the duodenum. The nutrients are absorbed as the intestinal contents move through that duodenum. Intestinal contents enter the large intestine, which is known as the colon. And then water is absorbed in that large intestine. That's the function of the large intestine, really, is to absorb the remaining water that's left over after all the other contents have been broke down in the small intestine. This is where producing more solid fecal mass, which then goes to the rectum. And here is the colon or large intestine with the ileum of the small intestine that empties into the large intestine at the cecum and through the ileocecal valve. And the appendix projects inferiorly from the cecum. So let's see here. Here's the appendix right here. That's what it's talking about. There's the cecum. The ascending colon coming over here to the transverse colon, and then the descending colon. Okay. Accessory organs of digestion. So we talked about it earlier about the salivary glands that secrete saliva into the oral cavity to moisten food. So think of that as the first chemical reaction that happens, but it's also that saliva that mixes with aspirin that causes that chemical reaction. So it's so important when you administer the 324 milligrams of aspirin so that platelet aggregation can start. It starts so much quicker when they chew those versus taking an 81 milligram aspirin tablet. Here we have the liver. So the liver, what's it do? Well, it's a big filter, right? It processes nutrients and medications. It detoxes substances from the blood like alcohol. We have your gallbladder, and it stores bile. And then we know the pancreas has that endocrine function of producing insulin, right? And it also has the exocrine functions. The abdominal cavity houses organs and structures of many body systems. And so, therefore, there could be many body system problems. And a lot of those problems start with symptoms like nausea, vomiting, diarrhea, constipation, back pain, bloating. I feel like I'm on a commercial for a medication and all the side effects that it could have. Anorexia, jaundice, rectal pain, hematemesis, melena, and that's why it's so hard when you have these problems. Let's say, for instance, you have a patient let's just say, for instance, you see 20 patients complaining of vomiting, back pain, and you go, okay, and normally what you think it's BS. There's nothing to this, and then you get that one, right, who has vomiting and back pain, and he's suffering from a AAA. So it's so easy to become complacent with abdominal pain, but also you just have to remind yourself when you're out there and you're running these calls and you've seen 50 of these and they all went to triage at the hospital and they're sitting there for hours, that number 51 might be the real deal. And so we have to really try to not become complacent and really take these problems for what they are. So, for instance, let's say you get somebody, again, nausea, vomiting, and back pain. And so you start palpating the abdomen. And you have some tenderness. Now you're going to check a blood pressure, and they're hypotensive. Well, now we have something to go with that, right? Now maybe this call number 51 is not so much of a BS call, right? Or they're tachycardic. And so what I'm trying to say is don't lose focus on what these signs and symptoms are and what they can mean. They usually will lead you to another step in the assessment process. Here we have the abdominal region, the organs, and the source of referred pain, right? Because referred pain is like, when you have generally an adult male patient with chest pain can have referred pain into the left arm, right? They're having cardiac related chest pain, but the pain's being referred into their back or their left arm. That's what referred pain means. So you can kind of go through here and look at the region, like epigastric region, stomach, pancreas, right? And so what's the source of referred pain? Well, it could be an AMI, or it might be an appendicitis. It's all over the place. because the reason why it's all over the place is because all these organs share a lot of the same nerve pathways. And so when pain receptors are activated, they share a lot of the same nerve pathways. And so that's why they can be so wide. So again, scene size up, we know all about all this, right? We know about determining chief complaint. The initial impression is so important because you have to take that. You really have to take 10 or 15 seconds and train yourself to stop and look at the patient and really tell, are they pale? Is this a normal color for this patient? Do they look sick? How are they answering your questions? Are they ready to answer your questions, or do they seem irritated when you're asking questions? What I'm trying to decide, is this patient sick or not sick? In your primary assessment, we know about that. There's no need to, we understand at this point in time in our career what a primary assessment is, and we understand what our secondary assessment is, but remember, let's get the vital signs and let's compare the signs and symptoms to the vital signs. Let's then get a medical history and let's compare what we know so far, right, with the medical history. So this is a presentation of problems associated with a specific organ. And so you could go through and look at the liver, for instance. Generally a steady, dull pain in the right upper quadrant. They tend to have a bleeding tendency. Why do you think that is? Because the liver is a huge filter for the blood. So if there's a problem with the liver, chances are good there could be something going on with bleeding. And also, patients with liver problems tend to be what? Jaundice. That yellow color of their face and eyes. When we're talking about hepatitis, well, it's a flu-like symptoms. Their liver can be enlarged and tender. Or if we're dealing with somebody with cirrhosis, and it's, oh my God, I know what it is. I don't know if I can say it. Cities, right? Sometimes those need to be drained, right? In cirrhosis, because it's leaking. And it leaks right there into the abdominal epigastric area, and that all that fluid causes respiratory distress. Gallstones is another big deal, man, and it's so painful. And the patient's usually so sick and so malicious from these gallstones. It happens when the actual gallstone obstructs the common bile duct, and it blocks that duct from being able to get rid of any bile. And so the bile backs up, and when that happens, they start having cramping pain, colicky. Colicky pain means like a really bad abdominal pain. It can last 30 to 60 minutes after eating, and especially a high-fat meal. So maybe this patient goes to a McDonald's, gets a quarter pounder, and next thing you know, 30 or 60 minutes later, they're in severe pain. Cholecystitis is a word for a gallbladder, inflammation of the gallbladder. And then the stomach, or gastric or pepsid ulcers, a disease. And this is a burning pain with nausea, vomiting. Hematemesis is possible. You can go through there. All of those are common problems that we run into in the field. Certainly see a lot of it in the hospital. Acute pancreatitis. Let's talk about the spleen, right? A ruptured spleen from maybe an MVC or some type of traumatic event. Sudden intense pain subsides and then intensifies, and may be accompanied by what? Syncope or orthostatic hypotension. Because if their spleen is ruptured, they're bleeding inside the abdominal cavity. And that's where the syncope comes from, having such a low blood pressure. aorta, the intense, so we can see an intense ripping or tearing pain in the lower back or abdomen that radiates down one or both legs. So think about this for a second. A lot of times these patients will complain of severe pain in their pelvis area because of that referred pain going down, it says one or both legs. Well, it may be going all the way down the legs, but the pain's so intense around the pelvis area that that's what they're really complaining about. They could have possible vascular or neurologic signs and symptoms in one or both lower extremities. Syncope, though, profound hypotension, shock, that feeling of impending doom, right? They literally say, if you don't help me, I'm going to die. I'm going to die, right? Good luck on a pulsating mass. I've never found one in my career, but who's to say that you won't? But the ones I've came in contact with had severe lower back and pelvis pain. And they're not always hypotensive unless it's already bleeding. And so these can be really hard to pick up in the field. So kidneys, I just want you to remember nephritis, right? And so inflammation of the kidneys, dull, constant flank pain, right? Kidney stones, right? I don't know if anybody's ran into that yet, but severe pain that usually, we call it flank pain. It's usually right or left, radiates from the abdomen to the back. Appendix, this is, appendix can kind of be hard to diagnose in the field. It says may begin with poorly localized periumbilical pain that usually localizes to the right lower quadrant. So it starts around the belly button and starts becoming more generalized as the time goes on into the right lower quadrant. These patients, if that appendix is ruptured, they have signs of something called peritonitis, when the peritoneum of the abdomen, the lining of the abdomen, becomes inflamed. A lot of times too, pain will start early morning hours and progress through the day and become more generalized to that right lower quadrant. Ovarian cysts in females. This is usually, they can also have similar pain, but actually I would say their pain is probably more severe than appendix type pain. This is usually the ovarian cyst will usually rupture, and that is good and bad in that. The good is it's ruptured, and now once the fluid is processed, it kind of goes away, but it could take several days for that to go away. And then we have ectopic pregnancy, and so we know that this is a life-threatening event for a female of childbearing age. We understand that really any type of abdominal pain in female childbearing age you should really consider it to be an ectopic pregnancy until proven otherwise. And that's just, you have to think like that because there's so many females that die every year of ectopic pregnancy related issues. And so again, it tells you it's hard to pinpoint a diagnosis in the field, and it absolutely is. Thank God that we have CT scanners in the hospital, because that's what's going to tell the tale. Anytime you have somebody having abdominal pain, they get an IV so they can get some IV dye, and they go to CT and they get that dye put in. And that gives us a pretty clear image of what's going on. And that's how we diagnose abdominal issues. So they can be anything from non-life-threatening to life-threatening. But we have to take them seriously because we don't know in the field. There's just no way for us to know that these problems could be life-threatening. So we can anticipate vomiting. AEMTs, you can administer Zofran, PO. You can do that to treat nausea. We can start some IV fluids, and just if they've been vomiting, we can replace any type of non-hemorrhagic blood loss that they may be suffering from. Put them in a position of comfort and then reassess that patient. So a lot of causes for abdominal pain: inflammation or infection, stretching of the tissues, and even ischemia, like a bowel obstruction. A bowel obstruction could cause ischemia. All right, this is a figure 24-6 that talks about pain from the abdominal problems can be referred to sites other than the location of the problem. So here we can look, excuse me, at the heart right here, right? We can see that that if it's cardiac related chest pain, it can radiate into the back. Here we have the liver can radiate into that shoulder. And you can kind of go through here and look at some of the referred pain. It would be a good idea to understand that, because there's always questions here and there that refers to this referred pain. I'm trying to see if there's any really good examples other than the ones I've already given. See any. Esophageal varices, also Mallory-Weiss tear, esophagitis, we call GERD, and hiatal hernia. And let's look at esophageal varices for a second. So here you have your spleen. These are the gastric arteries. This is your esophagus, right? And esophageal varices is when we have these vessels that are actually in the esophagus that come down, right? There's a backfill of pressure from the liver usually, and it causes that backfill of pressure causes these vessels to expand and sometimes bust. And these are the patients who are constantly vomiting blood. And so the more blood you have obviously coming up the esophagus and vomiting out, the worse airway problem you could have. And these are the ones, I don't know if you've ever had one of these or not, but these are the patients who you just put the suction in their mouth and you let them hold it because there's so much blood coming up out of the esophagus. So here is an esophageal varices right here. You can see like this vessel right here. Looks like it's busted at some point in time. Hiatal hernia, also gastroesophageal reflux. And that's just where some of us even suffer this from time to time. You have acid reflux. You have acid actually boiling up from the stomach, comes up the esophagus, causes that problem. Upper gastrointestinal bleeding or upper GI bleed. This is esophagus to the ligament of the teres. Below this point is considered to be a lower GI bleed. We have gastric peptic ulcers, inflammation or ulcers in the duodenum. This is when normally you have somebody who's vomiting blood on an upper GI bleed. Here we have another example of these gastric juices or acid because the stomach is very acidic, right? Has to be acidic to break down the food. And right here is the duodenum. This is going right into the small intestine, and sometimes acid builds up in that duodenum, causing a duodenum ulcer. That acid eats away at that duodenum. So gastric ulcers are the small red spots on the interior wall of the stomach, And the duodenum ulcers are the small red spots on the interior wall of the duodenum. So right there. These are the gastric ulcers right here. Oh, right there. Sorry. So burning in the upper quadrants, acute severe pain. They're going to be vomiting blood or a coffee ground type emesis. Could have melena. So we're going to do oxygen assist ventilations if needed. Hopefully most of these don't need assisted ventilations. Most of these just need a little transport to the hospital. Or we're going to give them a bunch of medicine to reduce that acid content in their stomach. We can put an NG tube down their nose into their stomach, suction it out, and let those heal. We do that by giving them a lot of base. Right, think of a lot of acid there. So we're going to give a medicine that's going to cause that acid to be more basy, reduce the acid content. That's going to allow those ulcers to heal. Gastroenteritis. It's an inflammation of the stomach and intestines due to the presence of a pathogen. These pathogens could be viral, they could be bacterial, or even parasitic. Right, so you go to the hospital. They send you to CT. They can't really find anything wrong. You're going to get a diagnosis of gastroenteritis. The appendix or appendicitis here is an inflammation of the actual appendix. Most of these are surgical and the appendix has to be removed. Then you have diverticulitis. So this is an infection of the diverticulum. And the signs and symptoms are very similar to that of appendicitis. And so you can have these. These are little, think about the large intestine, these form little pockets on the large intestine. So what do we have that comes through the large intestine? Fecal matter, right? And so if these pockets sometimes get tore by the moving of that, and what happens is they get infected. So when that happens, we call it diverticulitis. And so infection of the diverticulum. These little pockets are also known as diverticulosis, and when they become infected, they're called diverticulitis. So here's a normal appendix right here. And obviously here's the inflamed appendix. The goal here is to remove that appendix before it starts leaking, and then we have to deal with peritonitis. Here's the diverticula of the colon, and these are these pockets I was talking about. See, these form on the actual large intestine or the colon here, and as feces moves through, it opens them up. And when they get opened up, they get infected. And so that's a diverticulosis. Once it becomes infected, it's a diverticulitis. Lower GI bleeds beyond the ligament of Tourette's, hematochezia. We deal with that. Bowel obstruction. These bowel obstructions due to fecal impaction, tumors, right, or bands of adhesions in the abdomen from surgery. Could cause like a volvus, which is that twisting of the intestines at the cecum or sigmoid colon. Very painful. A bowel infarction. This is a portion of the bowel that's ischemic and it cannot function due to probably like a blockage, and so they have to go in and remove that part of the colon that's infarcted because it's not going to get any better, and then reconnect it. Hernia. A hernia is known as an abnormal opening through which tissue protrudes. They're very kind of common, really. Most hernias don't need to be repaired, but if that opening is allowing the intestines to come through that opening or whatever, then think about muscles hold those in place. And sometimes those muscles, for whatever reason, open up and allows the intestine to pop through. And that's a hernia. And as long as the bowel's not strangulated, causing ischemia, as long as that's not happening, then they're very easily repairable. Here's your small intestine, the colon, and there's that twisting portion of the small intestine, and that's called a volvus. IBD, or inflammatory bowel disease, it includes an ulcerative colitis and Crohn's disease. Crohn's disease can affect any part of the GI tract. Constipation. We see constipation a lot of times. There are a lot of elderly folks who are just losing that process of being able to have that smooth muscle move around and move that waste matter out. But also, sometimes if they're injured or they're hurt or they're sick and they're taking narcotics. Narcotics is a big deal to cause constipation. Usually doctors understand this, and they'll give like a stool softener with your hydrocodone or something like that. But yeah, so infrequent bowel movements with small hard feces due to excessive water absorption from the colon. Good old hemorrhoids. A lot of firefighters have hemorrhoids, and it's because of all the lifting and straining that we do. A foreign body ingestion, right? So treatment of a swallowed foreign body depends on the nature and the object and the location of the digestive tract. Most of these will continue from the stomach and go through the digestive tract without a problem. But sometimes, in some rare cases, they have to be removed. Pancreatitis, right? So inflammation of the pancreas. So acute pancreatitis is very painful and they're very sick. Digestive enzymes come in contact with the pancreatic cells, and that results in this autodigestion of the pancreatic tissue. We have Gray's or Turner sign and Cullen sign. So let's look at those. Here they want you to note the relationship between the liver and gallbladder and pancreas. So here we have the liver. Just underneath that of the liver, and you usually have to lift the liver up to be able to see it, is the gallbladder. And then look right here, so pancreas is right here. So it's just easy, for the liver to send out the bile to be stored right there in the gallbladder. Liver disease, hepatitis, has both infectious and non-infectious causes. Most are viral. Non-infectious causes typically from medication and toxins such as like Tylenol. That's why Tylenol overdose is so lethal. Can result in liver failure. They'll have upper right quadrant pain, sometimes left upper quadrant pain, nausea, they're very malice, fever. But jaundice is a big one for that, and that portal hypertension can lead to esophageal varices. Liver cirrhosis, we see this quite often too. Progressive disease caused by chronic inflammation of the liver. Normal liver tissue replaced by scar tissue. And this is, you can see these patients, chronic alcohol is usually what you see. But then when you say chronic alcohol abuse, I had a patient who died of liver cirrhosis, and she only drank for like a couple of years, and she wasn't really like your super heavy drinker either. I mean, she drank probably 3 or 4 or 5 drinks, maybe a drink a day, and I guess by all means she probably was an alcoholic, but she didn't start that till she was in her 30s before, so it was just terrible. So it doesn't always take years of chronic alcohol abuse to cause this. Cholecystitis is an inflammation of the gallbladder. This occurs from the presence of gallstones. And so your symptoms are usually, most of the time, vomiting, nausea, peritonitis type symptoms. So Zofran, PO, IV fluids if they're dehydrated. A pneumonia can cause referred pain to the upper quadrants as well. Remember myocardial infarction, especially in females, pain in the epigastric region. And when you're dealing with the spleen, we know it's highly vascular, and patients usually suffer, if it's ruptured, suffer profound shock. Kidney infections or kidney stones, flank pain, right side, left sided flank pain. Usually not both, it's usually one to the right or to the left. Aortic aneurysms. We know this is the weakened area of the aorta that might be prone to rupture. A dissection is the intimal lining of the aorta that allows blood to enter and separate the layers of the aorta. So the dissection here in this case is dissecting. The problem is if you suffer the aneurysm from it. All right, y'all. That's it. That's all for the abdominal chapter. Know your anatomy and physiology and your pathos related to gastrointestinal system. So everything that we covered, all the pathos behind that, relate the pain, the referred pain, all of that's testable. So understand all of that, from liver to aneurysms to all that. You usually have one sign or symptom that you could kind of cue in on, like liver cirrhosis, jaundice, right? Life-threatening, they can be life-threatening, but we don't know. We won't know till we go to the CT scanner to look at that. During transport, treat the nausea with Zofran, oxygen if you need it, IV fluids if they need to be rehydrated. All right. This is it. This concludes the chapter for abdominal pain and gastrointestinal disorders, and I will see you guys in class.